case actually is of a 56-year-old woman who she's very healthy. She has well-controlled hypertension, hypercholesterolemia, had a couple of ectopic pregnancies in the 90s, had a Van Steel incision to take care of them, but she's otherwise doing well, is relatively asymptomatic. When she was 50, she went for a colonoscopy. At that time, she had a benign polyp, which was removed. She went back 4 years later to have a repeat colonoscopy. At that time, they said there was something pushing in on her colon. So she went and had an ultrasound done, and it appeared as though there was an ovarian mass. I don't know if we want to see this now, or you want to show everything. We can. Yeah, why don't you come show it? We'll see that. We'll take a look at this. She was followed with this for this mass ultrasonographically. Didn't really change, although after about 2 years it was decided, well, she's starting to go through menopause. This mass hasn't changed. Maybe we should just get rid of it. So she did. Okay, go ahead.
Well, this patient came to us for an ultrasound in 2008. What the ultrasound showed was a right adnexal mass, and this is an ultrasound of the pelvis. This is these are two separate views. We can look at these three-dimensionally, and we saw an oblong tubular mass in the right adnexa. We could not identify the ovary separateness. At that time, it measured 6.0 by 3.0 by 8.0 centimeters. We recommended at that time an MRI of the pelvis to confirm that if this was ovarian in origin, especially given that colonoscopy finding, and to exclude other etiologies.
Okay. So the decision was made to proceed with the gynecologic oncologist to remove this mass from the ovary. They did a procedure, and they found out that although she had some fibroids in her uterus, her gynecologic organs were normal. Her ovaries were normal. Her uterus didn't have any of the lesions. They did see a mass in what appeared to be appendiceal mass that was.
Yeah, so actually what I actually had here is then she got a follow-up in 2009. Again, complex mass in the right adnexa. MRI recommended. 2010, complex mass right adnexa. It got a little bigger at that point in time. And then in 2011, she had an ultrasound that was subsequently followed by the laparoscopy. Okay. So then in 2011, we did the CT on this patient after the gynecologic procedure. And on the CT, there's a peripherally calcified complex mass, predominantly fluid density, and what you can see here, actually, what this turned out to be is a focus of fluid lateral to what appears to be a dilated appendix without a lot of inflammatory stranding surrounding it.
What about the liver?
Yeah,
I'm concerned
the
about the diaphragm. I'm concerned about the diaphragm.
Excellent observation. So the image that was going to follow. We doctors are so impatient. So there was a little bit of fluid around the liver, and in fact, there was also a small amount of fluid down in the pelvis. And what was significant about those findings was these small foci of calcification, which, if you recall from the CT, the coronal images, also peripheral calcification around this. So these could be dystrophic calcifications. I actually read this CT, and I was very concerned that this was a mucosal of the appendix and probably malignancy, with probably malignant peritoneal involvement as well.
So at the time of the gynecologic procedure, there was some implants right adjacent to the appendix on the lateral wall, and this was adherent to the what appeared to be a loop of the sigmoid colon. Mark, I don't know if
Yeah, I'm here. I can just say the examination of a biopsy of that mucinous deposit just showed mucin without epithelium, so acellular mucin.
Right. So that was on the lateral wall adjacent to the mass, the mass in the appendix. So she went to, took her to the operating room with the understanding that this may, it may be a solitary lesion. My thought was the fluid in the pelvis, fluid in the liver was very minimal, but it was right post-operatively, and there wasn't a lot of findings at the time other than what was right lateral to the wall. There was no mention of any findings greater or above the liver. This did track down a little bit along the pelvic sidewall, but that's where the mass itself was. You can see here, this is the left lobe of the liver is perfectly normal. This is the mesenteric ileocolic vessels coming up. This was approached laparoscopically through an infraumbilical incision. The major port was put there with the understanding that we would do an external anastomosis. This was again left lateral lobe of the liver. What was surprising was this suprahepatic finding. We were able to remove isolate the right colon laparoscopically and take down the sidewall adhesions laparoscopically. This suprahepatic peritoneal lesions, you can see there's a little margin here. This is normal out here. We were able to isolate this, put it into a plastic bag intra-abdominally, and bring it out through the umbilical port. At the time of the resection of the tumor itself, we put in this plastic bag. We made an incision along the abdominal wall below the umbilicus or belly button and put this plastic bag in. We were then able to bring this tumor up into the plastic bag, having taken down the lateral side wall, and make our anastomosis between the small intestine and the large intestine outside of the body, and then put it back in through a smaller incision. Once we found the lesions above the liver, there was contemplation of making a stem to stern incision, a bigger incision like the ones you've had or you've seen, and removing more. But this was a limited area, so did it laparoscopically. I'm glad there's other advocates of doing this laparoscopically, although I wasn't sure if this came from the implants were from the previous procedure. She did have some cytologic washings that were taken at the time. So question is now, she's doing well. We have a pathology. Mark, want to show that?
What was the time frame from the meeting? I know it was 2008.
Of the
cyst and the
2008.
Making a procedure at that time or no procedure?
No procedure.
Until now.
Until now.
And how long ago is this surgery?
May 25th.
So we had two specimens for pathologic examination, the right colectomy specimen and that mucinous implant, the suprahepatic mucinous implant. So within the right colectomy specimen, it was a portion of the ascending colon, the cecum with the appendix, the attached terminal ileum. We saw the mucinous mass surrounding the appendix, which was distal to where it came out of the colon. And sectioning through that mass revealed that there was a cystic dilatation of a lumen that was filled with this mucinous material, with dissecting or rupturing through the wall and forming the mass around the appendix with mucin and hemorrhage. So I'm going to show a couple representative sections. This is from the appendix closer to where it comes out of the colon. This is preserved appendiceal mucosa. You see the overlying, there's the overlying luminal, this is the cavities in the center, luminal surface, and the epithelial. The glands are crypts extending into the lamina propria with the inflammatory cells and associated lymphoid aggregates. As we go into the mass, you see the change in the epithelium. It's becoming villiform. Over here it's a little flatter but undulated. You see there's a loss of that of the lamina propria and associated lymphoid tissue, and the epithelium itself is a little here. In some areas it's just a single layer of columnar cells, mucinous producing cells, and then as you go along you can see that there's pseudostratification, but there's still orientation. So this is low-grade dysplasia, and it's not invasive or adenomatous change. And as we go into the area of the rupture, here's some of the residual wall of the appendix. This is the outer surface of the appendix. You saw before we had the muscle. Here it's all the muscle's gone. It's replaced by a hyalinized fibrous tissue scar. Here's some of that calcification that was seen on X-ray. And here's the mucin dissecting through that area of rupture. And we don't see epithelium within this area of rupture, and also examination of all the mucus implants that we got for pathologic examination was acellular. So in summary, this is a low-grade appendiceal mucinous neoplasm with a spread of mucinous, acellular mucinous peritoneum.
The patient preoperatively did have another colonoscopy, which did not show anything, and the tumor mass itself was adherent to the sigmoid colon. This partial resection of the colon was undertaken. It was a wedge resection, not a complete resection, but outside of the limits of the tumor. So in terms of cytoreductive surgery, it appears as though the majority of this tumor, if not all of it, is removed. The question is, what do we do now?
And the piece of sigmoid that was removed, what did the pathology on that show?
It was normal.
Normal. Again, no epithelial cells in the mucus outside the appendix.
Correct.
Okay.
I'm going to leave 5 minutes before the rest of the audience.
I would have managed this a little bit different. I think the standard of care for patients with mucinous tumor of the appendix should be high-pack. And if you cannot do the high-pack, then unless the patient is obstructed or having a problem, you do laparoscopy. The patient should be closed and referred to a center that can do all the procedure. I think right now she needs a high-pack. It's not required the resection of the previous site because it's a high likelihood of leukorecurrence and maybe the sigmoid area. And I think the problem with previous surgery that had not been complete is what happens with the second operation. It becomes more difficult because everything's stuck together. These scars will have to be removed as well. And I think the standard of care for this patient should be high-pack from day one. And I think when you look at the initial diagnosis, it's saying everywhere there's an appendiceal cancer with mucinous dissemination. And it's a lot of other procedure to deliver that goes all the way back. That needs to be addressed as well. But I think
we did not see that at the time of laparoscopy. There are limitations with that view too. The small bowel and the omentum, nothing else was involved, just as an observation.
I would put this patient into follow-up. What that follow-up should be, I think, is an interesting discussion. she does have a poor prognosis. By the Mass General study, those low-grade malignancies which had, quote, breached the wall of the appendix, even though there was no epithelial cells and mucus outside the appendix, they did have a poor prognosis. 30% of them were alive at 5 years later. So she does have a guarded prognosis, but you've not identified her as a pseudomyxoma peritonei patient. And it is a low grade, as nicely shown on the pathology. It is a very low grade of malignancy, or it is a very low grade tumor. It's a low grade mucinous appendiceal malignancy, low grade LGAM, low grade appendiceal malignancy. I would put her into follow-up and see how she does. Our standard would be CT scan every 6 months and some tumor markers, but I am not so sure that laparoscopy, repeat laparoscopy, is not an important part of that paradigm. But I don't do that.
I think I would get the tumor markers and an MRI.
Okay.
So I think if you're able, as Armando's, first of all, I think the four of us would agree that the patient has residual disease. The chances that the patient has residual disease are high.
I'm not so sure. I'm not so sure. If you don't identify tumor cells outside the appendix,
No.
you can't make a diagnosis.
Even the residual, the mucinous implants. I mean, what we saw there on the liver, like Armando said, very likely if you look more on that paracolic gutter, there's a good chance that you're going to find disease there. Now, MRI is pretty good at picking that up, even the small implants. So I would start with that, and then it's depends on what you find. I don't like the CT scans as a follow-up because if this patient has a good prognosis, you're going to be exposing to radiation to this patient every 6 months for many years, and it's going to end up developing a secondary malignancy from the radiation.
Laura?
Yeah, I would agree with pretty much everything. Definitely the tumor markers. Definitely some sort of follow-up, whether it's the CT scan or MRI. My couple observations: the calcifications that were behind the liver, and the calcifications in the appendix obviously suggest that this has been going on for a long time.
Yeah.
That in the pathology that was demonstrated suggests this is indolent, at least for now. So, I don't think you have to be concerned that if you are screening her every 6 months, she's going to come back in a situation where she can't be treated for cure. But you do need to keep a close eye on her, because I think it's very likely that she is going to recur. And at that time, the definitive treatment would be cytoreductive surgery and heated intraperitoneal chemotherapy.
She did have a CA, which was normal. I ordered a CA 19.9. I don't know if anybody else is using that.
Always.
Yeah, CA 125 too.
And 125.
And I didn't. She had the CA 19.9 order, but I didn't see the results. I don't know that she got it.
I mean, we have evidence that this has been there for at least 3 years.
Yeah. Would anybody give her intravenous chemotherapy?
No.
No. There are people in this group who want to be explored a year later and want to be sure that they don't have continuing disease. And I have gone ahead and explored at least a half a dozen patients who had 5 children and were wondering all sorts of things about the rest of their life. And the diagnosis rate with the negative CT scan in this kind of a patient is 50%.
You do your exploration laparoscopically, or?
I have always done it open, but I am not. I am not sure that laparoscopic would not be adequate, but I have always done it open.
In patients like this, what I tell the patient, there are high chance of recurrence if they still don't have disease. I recommend laparoscopy if the patient is very worried about it and cannot be followed. Again, I think this patient, I'll be surprised that he doesn't have disease somewhere that actually will be visible by CAT scan or MRI.
How soon after the operation would you get a CAT scan? Every 3 months or?
No, I never do every 3 months. I think I've been showing that. I will do a baseline so you have something to compare. Now, if you did a baseline, it's already using, you do if the patient is very worried, laparoscopies, I have patients who have actually a lot of tumors that were completely washed out in surgery that for some reason we never did any operation and they're out 5-7 years and never recur. So it's not everybody's going to refer. We just don't know who is the issue. I'm just concerned about the diaphragmatic area has a lot of, it's all the way back and you only remove this much. So I'll be concerned that the rest of the diaphragm has more disease.
And in patients like her, if you take out the omentum, you'll find mucin, some mucinous deposit. In our series, he was in the 12 out of 13.
Very hard. I mean, he already has.
But mucin is not a tumor. I mean,
But mucin is
you've got to
target.
have tumor cells in that mucus because there could be a lot of mucus.
Yeah, but that's how that diaphragm starts. And then it gets bigger, and then what? So,
But it's a low grade tumor. You're not going to lose with follow-up. You're not going to lose this patient. She's still going to come to.
oh no, I understand.
She's going to be cured of her disease.
So like I said, like you mentioned it too, it comes down to the patient. I think that some of the patients that don't want to have the uncertainty. I don't want to have the uncertainty ruled out with a huge incision. Because then, there's no question that a huge incision with a negative is kind of like screaming victory, but you have the evidence there now. But so those patients I approach like in between, well, let's do it laparoscopically. We do a diagnostic laparoscopy, we look around, we know where to look. If you have a limited carcinomatosis, we remove it laparoscopically. If it's more, then we open them up.
The MRIs, how frequently would you get the MRI?
Well, see, that's the advantage of the MRI is that there's zero radiation. The disadvantage, it costs more. At our institution, it's $700 for a CT scan, $1,700 for an MRI. And we're putting our data, we have now 25 MRIs, and so we're looking at all those things. So I think that every 6 months is appropriate, but quickly move to, every once a year.
Would you do anything differently, or?
No, I usually start with in the early, right after the diagnosis, and you're starting your surveillance, and if you don't really have a sense of the tumor biology, I will do usually every 4 months for the first couple of years. And I'm still routinely using CT scan, but we are moving to MRI. And then in selected patients, again with that, the person who just wants to confirm that what the CT scan is showing is real, I will use diagnostic laparoscopy for those patients.
And in terms of the tumor markers, do you do them at 4 months?
Absolutely, with the HCT scan, CEA, CA125, and CA19-9. And typically, they will actually start to go up sometimes, in my experience, that they will actually go up. If they go up, your next CT scan will show you where the disease is, or you'll be prompted to put the